continue. We will continue with this autonomic nervous system on Friday. And I think, after this autonomic nervous system, we are nearly done, or we have done almost everything except the special sentence and some of the, very early page of our textbook, like liver system or that sort of stuff. So we will spend maybe about 1 or 2 more lectures, which means like next week, Wednesday, we will finish our anatomy classes. Not finish our anatomy classes, we will finish our textbook so that we can do the revision starting from, let's say, next week, Friday. So that's what I hope. And I think, so what day is today? Today is, let me check, I'm sorry. So 19 November, Friday, we might have to continue with the autonomic nervous system. And after that, on 22nd, we will do, let's say, special senses. It is not a big lecture. It is just for your general knowledge so that, you have a basic knowledge about these special sense organs. And on 24th, then, we will, 24th Wednesday, we will have like, might be a little bit of revision or everything. Then 25th is Thanksgiving, and ask yourself whether you want a class on 26th, Friday, if you want to take a break, or do you want a little like revision, very soft anatomy to revise everything. We can start on 26th of November, Friday. We can do that. I think it will be nice, whatever you say, like if you want a break on 26th Friday, that's fine. If not, we can start our revision on 26th of November, Friday, and then 29th, Monday, 1st of December, 3rd of December, and then we will start our exam on, let's say 9th of December. Yeah, shall we do that? 9th of December. If anyone has any issue, yeah, please post on the chat box so that I will have a look. That's what I'm just thinking out loud. What we should do. And from 9th of December, which is on Thursday, we open the exam for 1 week, and we will finish on 16. Let's say that will be a plenty of time. 16, because on 17 is the last day of the semester, which means we cannot extend the exam beyond that point. So like everyone, please do the exam before 16, because after 16 I cannot open the exam anymore. And if anyone stuck with any issue, then it damaged the whole semester grade. So don't do that. Please finish the exam before 16, and 17 will be the last day of the semester, and we have to report the grading like within like 1 week to the dean's office. So if we don't do that, we get into trouble with all the paperwork and everything. So we will open the exam. Just wonder whether 8th or 9th. What do you think?
The sooner the better.
The sooner the better. I think we will open the exam on 8th December. Yeah, 8th of December. So let's do that. And then we will finish the exam on 16, so that you got 8 days to do the exams. Like it's one attempt because it is a final exam. There will be the same like your monthly exams. You're the same like your monthly exams. So like there will be lab and lectures. Lectures might be might be about 50, lab might be about 30, 35. I don't think I will go for 40s. So that, just please do the exam before 16, because on 17, all the class, the semester is finished, and my canvas will be frozen by the college. So I cannot do any more after the 17th. So please do that. Please do that. I want to give you a pass, but it need to be a documented pass. We have to show you have done the homeworks, you have done the exam, you have. That's why you passed the exam, or that's why you got the grade A or grade B. So all these are documents from our side. We need to be accountable. So like, we are not giving the students A just because you are my student. We are giving the students A or B, or just because you have done the homework, you have done the exam. So these are the formal assessments, which are really, really important, at least on the paperwork. And there is a reason why we give you A, or there is a reason why we give you a pass. So please do the exams. We open the exam on 8th of December, which is Wednesday, and then we will stop the exam on 16. 17 will be the canvas. Our canvas we got frozen, and we cannot do much with the canvas, and we cannot open the exam and that sort of stuff. Okay, so I hope we have a good time during the semester. I think next spring semester is going to be a lot more difficult. I believe you have heard of that. Like, everyone, like lab sections, we have to come back to the college. So there are 3 days a week for the anatomy class, and 2 days we have to be in the lab. So in the lab, we cannot use any video recording. And that means, like, if you do not come to the lab, it is going to be a big deal. So it's not easy. So now we are, because of the COVID, we are a little bit easier, just online, everything online. So let's start with the autonomic nervous system. Autonomic nervous system. It's autonomic. I mean, it is on itself, on its own. I mean, yes, you can influence on this autonomic nervous system, but this nervous system is doing its own job without our influence. We can influence this, but they will do their own job without any, like higher center like brain and spinal cord influence. So that is the autonomic nervous system, which we are going to talk about. So this is the diagram we talk a lot during the central nervous system, peripheral nervous system. Let's have a look, and let's repeat this again, because this is the basic of our nervous system. And a nervous system can be divided into structurally, not functionally, structurally divided into central nervous system and peripheral nervous system. Easy, central nervous system means brain and spinal cord. Anything inside the head, anything inside the spinal canal, brain and spinal cord, it is central nervous system. So anything other than brain and spinal cord is going to be peripheral nervous system. So peripheral nervous system, so cranial nerves coming out from the brain. So it is not in the brain, and therefore they are part of the peripheral nervous system. So any peripheral nerve, like radial nerve, ulnar nerve, they are peripheral nervous system. So brain and spinal cord is the central nervous system, and the rest is peripheral nervous system. As we know, the peripheral nervous system can be functionally divided into sensory and motor. Of course, being touched, being pressured, or being heat temperature, all these sensations come into our body through the sensory nervous system, or which is also called afferent, A-F-F-E-R-E, afferent coming into the brain and spinal cord along the peripheral nerves. And if we need to, we will react with the motor system. So touch, heat, come back out. That's backing out is motor. So sensory and motor involved in the peripheral nervous system. Yes, sensory can be like somatic sensory, which means like, like skin or any touch, temperature, pressure, proprioception. These are the somatic sensory sensation, or the visceral sensory sensation, which are like stomach pains, like, high acid pain in our stomach. That is the visceral sensory. That is the visceral sensory system, which will come along the sensory nerve, and we come to the spinal cord, and we go to the brain, and we come back and react as appropriate. So that is the somatic sensory and visceral sensory for the sensory afferent division. For the motor division, we also have the somatic motor and visceral motor. Somatic motor means voluntary control, like skeletal muscles. So you want to touch it, your hands go there. You want to back out, your hands can back out. So that is under your control, your voluntary. So that is what we call somatic motor system. And today we are going to talk about autonomic nervous system, which is for the motor movement of all the viscera in our body, like heart, lungs, gastrointestinal tract, liver, gallbladder, pancreas. These are doing their own job without being asked to do so. Yeah. So you are not asking the heart to beat. It is beating on its own. So that is autonomic. So autonomic is for the visceral organs. Autonomic nervous system is for visceral organ, motor system. Yeah, visceral. So we are not asking our heart to beat. We are not asking our lungs to breathe. We are not asking our gastrointestinal tract to, hey, go and absorb. Hey, secrete out. Hey, absorb more water. We are not asking to do them. They are doing on their own. That's why they are called autonomic nervous system. Of course, we can influence the autonomic nervous system through our higher order organs, like brain. If you think something exciting, your heartbeat will go up. If you think something distracting, your heartbeat will go up. Your respiration will go high. So these are, of course, we can influence with our brain, but without being influenced, they will be doing on their own job. So this autonomic nervous system can be further divided into sympathetic division and parasympathetic division. Sympathetic division, we act on the heart. Parasympathetic division, we act on the heart. But sympathetic division, we increase the heart rate. Parasympathetic division, we decrease the heart rate. If they are balanced, we have a good heart. Yeah, our heart rate is not high, not low, it is optimal. So we need this balanced sympathetic and parasympathetic division in all the organs, which is supplied by the autonomic nervous system. So we are going to talk about the autonomic nervous system, which includes sympathetic and parasympathetic division. Yeah, so parasympathetic division is for the conserve the energy. So usually we say, hey, parasympathetic, it is rest and relax. So let's say if you had your big breakfast and you are a little bit tired, and then you feel okay, and you are just sitting in front of the computer and listening. So that in that state, you are in a parasympathetic state. So you are resting, your gastrointestinal tract is doing the job, digesting the food you have eaten. So they are working, and your heart rate is a bit low, and there is no exam and no homework. I'm having a good time. So the heart rate is low. So that is for the parasympathetic. So sympathetic is, hey, we have homeworks to do, we have exam to do. Then your heart rate will go and beat up, and then finally become increased heart rate. That is the active sympathetic. So sympathetic is for the fight and flight situation, like when you are fighting or when you are running. So that's sort of, so these two systems need to be balanced. So let's look at the sympathetic and parasympathetic nervous system anatomical formation carefully. So this is the diagram taken from Canal Medical Physiology textbook, and we have our spinal cord here, midbrain, pons, medulla oblongata. And then come down here, this is the spinal cord. So this is the spinal cord. And here's thoracic 1, 2, 3, 4, and go on and on thoracic. This is the cervical spine. This is the cervical spine. This is the thoracic segment of the spinal cord. And this is the lumbar segment of the spinal cord. And this is the sacrum segment of the spinal cord. Yeah. So midbrain, pons, medulla oblongata. This is the cervical segment of the spinal cord, thoracic segment of the spinal cord, lumbar segment of the spinal cord, and sacrum. So I hope you get the idea of the diagram. And if you look at that, let's start with the sympathetic. Here, sympathetic written here, and parasympathetic is written here. Let's start with the sympathetic. So the sympathetic nervous system, so the spinal nerve from the thoracic 1 region come out. Thoracic 2 region come out. 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 come out. And lumbar 1, 2, 3 come out. And where do they go? Let's look at that. Where do they go? They go to these structure, like a little bead structure on the side of the spinal cord. So we have this sort of change on the left side as well. This is the chain on the right side. There will be another chain on the left side. We have removed it for the clarity of the diagram. So what do we call this chain? We call it sympathetic chain. So these little beads along the chain, they are called sympathetic ganglia. So now you understand sympathetic change on right side and on left side of the spinal cord or the vertebra. And these sympathetic change have sympathetic ganglia, little beads here. What is a ganglia? Ganglia is the accumulation of neurons. So the spinal nerve from T1 come out and go into the sympathetic ganglia. T2 go to the ganglia. Down to lumbar 3 go to the ganglia. Hey, look at that, multiple ganglia, and this is along the sympathetic chain. Or sympathetic chain, you can also call sympathetic trunk, the same. So along the sympathetic chain or sympathetic trunk, we have the sympathetic ganglia. And the neuron from here to there, it's just stop here. And there will be another neuron starting in the ganglia, leaving the ganglia and go to the target organ. Look at that. Look at that. So there will be exchange around the synapse. First, this ganglia to another ganglia, and then this another ganglia neuron will leave the ganglia and then come to the target organ. So what do we notice? The sympathetic start from thoracic 1 to lumbar 3. That's why we also call the sympathetic system as thoracolumbar outflow, because their nerves originate from the thoracic and lumbar spinal region. So therefore, sympathetic is called thoracolumbar outflow because the neuron come out from the thoracic region, go to the sympathetic chain. And if we look at that, this neuron from the spinal cord to the ganglia, and there will be another neuron from the ganglia to the target organ, from ganglia to the target organ. This neuron, this axon is pretty short, and this axon is pretty long. We call this segment preganglionic neuron, before the ganglia. So preganglionic neuron, this is the preganglionic neuron, and this will be postganglionic neuron. So that is the way, the anatomical formation of the sympathetic nervous system. So what about the parasympathetic nervous system? So it is arising from the brainstem, midbrain, pons, medulla oblongata. Hey, look at that. These are the cranial nerves coming out from the brain and go here. Cranial nerves 3, 7, 9, 10. Look at that. Cranial nerve 3, 7, 9, 10 come out from the brainstem, and they go to the ganglia here, parasympathetic ganglia, which the name is depending on the site. Around the eye, we call it ciliary ganglia, the optic ganglia, submaxillary ganglia, and they go to the ganglia, and like the sympathetic, there will be a synapse and another neuron leave and go to the target organ. So what do we notice? This is our preganglionic neuron, and this is the postganglionic neuron. So now, presynaptic or preganglionic neuron are here. That's for the parasympathetic, and this for the sympathetic. And postsynaptic or postganglionic neurons are, this is for the parasympathetic, and this is for the parasympathetic neuron. So what is the difference? The difference is presynaptic neurons in the parasympathetic system are pretty long here. They go along here, and then they go close to the target organ. They go into the ganglia and synapse, and they leave. So their postganglionic or postsynaptic neurons are very short. Look at that. Opposite, in the sympathetic system, their preganglionic neurons are shorter than the postganglionic neuron. So I hope, and again, on top of that, this parasympathetic, their fibers leave from the brainstem, midbrain, pons, medulla oblongata, and the sacrum. And therefore, we call their outflow as cranial, because cranial from the brainstem, and sacral, craniosacral outflow. So this is what we call thoracolumbar outflow, and parasympathetic we call craniosacral outflow. Why do we call craniosacral outflow? Because they are presynaptic or preganglionic neuron come out from the brainstem and the sacrum. Why do we call thoracolumbar outflow for the sympathetic? Because they are neurons come out from the thoracic and lumbar region. And in sympathetic, the preganglionic neurons are short, postganglionic neurons are long, and in parasympathetic, preganglionic neurons are long, and postganglionic neurons are short. So this is a really lovely diagram. I think if you look at that again, you will appreciate what it is trying to say. So yes, of course, this is from our textbook. We have the motor system. Motor system has got somatic motor, like our voluntary muscle motor with our hands, head, neck, whatever we do, skeletal muscle movement, somatic motor. And we are talking about the autonomic nervous system, which is the sympathetic and parasympathetic division. And we know that parasympathetic division come out from the brain and brainstem, like cranial nerve 3, 7, 9, 10, or the sacrum. Therefore, we call it craniosacral outflow. And in the sympathetic, they come out from the thoracic and lumbar region, and therefore we call it thoracolumbar outflow. So now look at that, we got this diagram. we have brain and the spinal cord here, which is the central nervous system. And now everything come out here. This is coming out, originating from the brainstem. 3, 7, 9, 10. Brainstem originate parasympathetic. Look at that. This deep blue color come out from the brainstem, and they are parasympathetic. Of course, sacrum, nerve origin come out from the sacrum. Therefore, we call them craniosacral outflow. For the parasympathetic, they are here. They are here. Look at that. From the thoracic to lumbar 3 region. Thoracic to lumbar, therefore, we call it thoracolumbar outflow. And they have to go into the sympathetic chain here. And there will be another neuron start in the sympathetic chain and go to the target organ. Therefore, in sympathetic post-ganglionic neuron or post-synaptic neurons are long, and in parasympathetic presynaptic neurons are long. They go close to the target organ, and only then when they go to the target organ, look at that, there will be little synapse, and there will be another neuron, post-ganglionic neurons arise here. They are very short. So that is the formation of the sympathetic and parasympathetic deviation. Of course, you know, we know that we have the numbers of the vertebrae and the number of the spinal nerve roots coming out from the spinal cord. And if you think like that, you know, where are the cranius, the cervical region, spinal nerve root? Of course, they go and combine. Some of them go and combine with the upper thoracic roots. So that's why, you know, the sympathetic change does not go up to the cervical region. Some of the cervical nerve roots will come down and will come to the first thoracic ganglion. So now we are looking at the spinal cord again. And this is the spinal cord. And this is the posterior root is for sensory, anterior root is for motor. So anterior or ventral root is for motor, posterior or dorsal root is for sensory. We know that. And for the sensory, there are two types of sensory. Sensory coming from the visceral organ, visceral sensory, and sensory coming from the somatic skin, hair. So somatic sensory, so one is colored with light blue and one is colored with green. They will go from the posterior root. There will be posterior root ganglion, and then continue and come into the posterior horn of the gray matter of the spinal cord. Look at that. And we know that their nerve neurons have different region, like somatic sensory neurons are very much posterior, and visceral sensory neurons are a bit more anterior in the dorsal posterior horn. And again, like motor neurons leave the anterior horn, and the motor neurons for the somatic motor are very much anterior, and motor neurons for the visceral motor are, visceral motor means for sympathetic and parasympathetic, they are a little bit more lateral and posterior, but they both leave from the ventral root or anterior root, and they form the spinal nerve here. So when we are talking about the sympathetic, parasympathetic, or autonomic nervous system, we are talking about the motor neurons originating from this visceral motor region, and our sensory neurons are going into the visceral sensory region. So these areas are related to the autonomic nervous system, and these areas are related to the somatic nervous system. So whenever we talk about autonomic nervous system, when we are associating with the spinal cord, the neurons for the autonomic nervous system are situated in this region or this region. So yes, there is a difference between sympathetic and now parasympathetic nervous system. You have seen it already. You know that origin, hey, it's origin for sympathetic thoracolumbar, origin for parasympathetic craniosacral. Hey, which cranial nerve? It's not all the cranial nerves, only the cranial nerve 3, cranial nerve 7, cranial nerve 9 and 10 involved in the autonomic, involved in the parasympathetic nervous system. So these third cranial nerve, 7th cranial nerve, 9th cranial nerve, and 10th cranial nerve, they will carry the parasympathetic fibers. They will carry the parasympathetic fibers, and of course in the sacral region. The location of the ganglia, you saw that already. Here, the location of the ganglia, you saw that already. In the sympathetic, the ganglia are along the sympathetic chain or sympathetic trunk. Hey, parasympathetic ganglia are close to the visceral organ. You have seen it already. So length of the pre and post ganglionic neurons in sympathetic, short preganglionic, long postganglionic. In the parasympathetic, long preganglionic, short postganglionic. Remind communicantes, that is the, like, yeah, as you saw, like we have it, gray remind communicante, white remind communicante. It is only present in the sympathetic, but it is not present in the parasympathetic. And degree of branching of the preganglionic axons is multiple, is excessive. So we'll talk about that later. We haven't seen it yet. And functional role is for fight and flight, and parasympathetic is for digest and rest. Neurotransmitter in sympathetic is acetylcholine. And in parasympathetic, again, acetylcholine. Look at that. So acetylcholine plays a big role. Of course, we have to do a physiology lecture to understand what sort of neurotransmitters we are using. But generally, it is acetylcholine. Okay, so this is the difference between sympathetic and parasympathetic. So autonomic nervous system is for the motor system for the visceral organ, which includes sympathetic and parasympathetic nervous system. Sympathetic is fight and flight, parasympathetic rest and digest. Sympathetic is thoracolumbar, and parasympathetic is craniosacral. And to the visceral organs, blood vessel, erector pili, sweat glands. All the visceral organs. Hey, we'll talk a little bit more about this. Fiber branch profusely, localized and decreased. This, if this nerve is for this, and it is only there. So it is where parasympathetic is more localized, sympathetic is wide and extensive. So now let's look at this diagram. Again, like it is which organ is being supplied by which portion of the autonomic nervous system, either sympathetic or parasympathetic. Let's start with the easy bits. Look at here, kidney. Look at that here, kidney, you have kidney. There is no supply for the kidney from parasympathetic, only the sympathetic. Look at that, no effect. And comme ça, look at that, comme ça. Yeah, blood coagulation, cellular metabolism, adipose tissue, mental activity. There is no parasympathetic. Look at that. So the way we have to do is we have to pick up the salient points and the rest become easier. So both sympathetic and so the way we try to remember is any organ in our body, we have sympathetic and parasympathetic, except kidneys, no parasympathetic, except cell metabolism, adipose tissue, mental activity, no innervation. What about lungs? Lens, yes. Oh, liver, look at that, liver. Liver, there is no parasympathetic. Oh, look at that, sweat glands, no parasympathetic. Erector pili muscle, like little muscle, which makes you a goose king. Bang, there is no innervation. So what can we learn from this diagram? We say every organs, every visceral organs, which are out of our control, even the hair follicle, they are innervated or they are supplied by the sympathetic and parasympathetic, except kidney, liver, adipose tissue, cell metabolism, mental activity. So that's the way, we just try to remember. Look at that, one important here, blood vessel. There is little or no effect. So your blood vessel constriction or your blood vessel relaxation, it's all depends on the sympathetic. Parasympathetic is negligible. In some of the textbooks, they say there is no parasympathetic for the blood vessel. This textbook will say a little or no parasympathetic. So the way we try to remember is clear cut, no sympathetic for the blood vessel and no parasympathetic for the blood vessel. So now we know which organs are supplied by sympathetic and which organs are supplied by the parasympathetic. So the way we try to remember, every organ in our body, we have sympathetic and parasympathetic. They need to be balanced, except liver, kidney, blood vessel, adipose tissue, cell metabolism, and mental activity. So now, it's just bit easier to remember. Every organ, we have sympathetic and parasympathetic that need to be balanced. Bang. So what is an honor syndrome? So honor syndrome, it is a clinical condition. It is a clinical condition. Syndrome means a few little bits and mixture of bits and pieces, like of the clinical signs and symptoms. That is what we call syndrome. Syndrome means, hey, this patient has got ptosis. This patient has got meiosis. This patient has got anhidrosis. Anhidrosis means sweat, anhidrosis means no sweat. So this is the clinical condition which is called honor syndrome. And look at this lady. So what do we see in this lady? We see, hey, it's interesting. Can I ask one of you guys, what can we see on this lady's eyes?
Her left eye is not like fully dilated and it's like a lazy eye.
Yeah, so this right eye is fully dilated, left eye is lazy eye. The eyelid is dropped, the pupil is small here. Look at that, pupil is wide open. Yeah, this is black pupil. This is small pupil. Brilliant. And eyelid is dropped. And if you touch this lady's left face, there is no sweating. So that is what we call honor syndrome. The dropping of the eyelids, which is called ptosis. So the small pupil, it is called meiosis. And there is no sweat, anhidrosis. Very good. I'm going to show you another slide. Bang. What can you see here? The same, isn't it? Yeah, the same. This guy, this gent, no, this gent has got ptosis, eyelid drop, meiosis, small pupil. This is white and normal eye, upper eyelid, ptosis, meiosis, and if we touch it, there is no sweating. Ptosis, meiosis, and anhidrosis. That is this combination is called honor syndrome. why is that? If we see somebody like that, what do we need to do? We need to check the lens tumor. So what is that? Look at that. So yeah, of course, I got the X-ray, only this X-ray, which is here. If you look at that, this is the chest X-ray. This must be a lady because we can see the breast shadow here. We can see the breast shadow here. The cardiac apex is pointing to the left side. And you can see here, little here, shadow. What is it likely to be? It is likely to be malignancy. So this Horner syndrome is not uncommon presentation of the lungs malignancy. So that is what is going on with the Horner syndrome. What is going on with the Horner syndrome? So the patient has got ptosis, the patient has got meiosis, the patient has got anhidrosis. You take an X-ray for the chest, and you see the tumor in the apex of the lungs on the ipsilateral side, so on the Horner syndrome side. Let's say for these two patients, there will be tumor in the left apex of the lungs. That tumor is example that we call Pancoast tumor. Of course, there are other causes for the Horner syndrome, like syringomyelia, carotid and so surgery. What's happened? Because the thoracic 1 cervical ganglia, stellate ganglia, the first thoracic ganglia, which can be fused with the 8 cervical ganglia, cervical nerve as well, that is supplying the phase of the eyelid, pupil, and the sweat gland for the eye. So that is the feature of the sympathetic chain injury caused by the cancer or the surgery, carotid endarterectomy, or might be syringomyelia, which is the dilatation of the central canal of the spinal cord. So that is the Pancoast tumor. So where they come from, the motor nerve come from the visceral motor region of the gray matter of the spinal cord, from the cervical 8 and thoracic 1 stellate ganglia, that in that area has been damaged. So all these, we have to remember the somatic sensory, visceral sensory, visceral motor, somatic motor, and they will come out here like that. So these motor neurons is coming out, motor neuron, look at that. Sympathetic preganglionic neuron, look at the neuron here. They are located in the anterior and lateral and leaving the spinal cord from the ventral root, here, written here, ventral root, and they come here. They were around the white rami communicantes. They will come here, look at that, into the sympathetic ganglia, and there will be a synapse. Synapse means the connection of the first neuron and the second neuron. Now look at that. This is the neuron. Look at the neuron cell body. This is the axon coming on, running along here, coming from the white rami communicantes, coming into the sympathetic chain, sympathetic ganglia, and there will be an end of this neuron, and there will be beginning of the another neuron, which is colored with blue, and this neuron leaving the sympathetic ganglia and running and going to the target organ as post-ganglionic neuron or post-synaptic neuron. Look at that. Look at that. Pre-ganglionic neuron, and this is the preganglionic sympathetic neuron, and this is the blue color is post-ganglionic sympathetic neuron. Of course, not every neuron will synapse at the same level. We have seen it already. Some will go one or two level up and then synapse and leave, or another will go 1 or 2 level, go down, synapse and leave. or some of them will not do any synapse at all and go there and go to the prevertebral ganglion, another ganglion here, and they will synapse and they will synapse and they will go to the target organ. So there are three ways. There are three ways for the presynaptic and postsynaptic neuron to join each other. The first way is at the same level, preganglionic neuron or preganglionic neuron comes in and the synapse and leave as a postsynaptic neuron at the same level. Second way, they will go up or they will go down, and then they will synapse and another postganglionic neuron will leave. Postganglionic neuron will leave. Or number three way is they do not synapse in the sympathetic chain. They will go to the prevertebral ganglia, and then they will synapse and then they will leave. So now I'm talking too much about the sympathetic change, preganglionic, prevertebral ganglia. So as we know, we have two sympathetic chain, one on the left and there will be one on the right. So what about the prevertebral ganglion? What about the prevertebral? There is no right and left prevertebral ganglion. The name is prevertebral, just in front of the vertebra, and there is only one vertebra, and therefore we will only have the one single, just in front of the vertebral body, only like one line of the prevertebral ganglion. There will be two lines for the right and left sympathetic change, but for the prevertebral ganglion, there will be only one in front of the vertebral body. So that is the sympathetic, the way they come out from the spinal cord and the way they enter the sympathetic change and synapse in the sympathetic ganglion and leave the sympathetic ganglion as both sympathetic neuron. Look at that. We have the right and left sympathetic chain or sympathetic ganglia. And we know that in sympathetic, we have the white rami and gray rami. Look at the rami communicantes, white rami communicantes and gray rami communicantes. And these coming from the spinal cord, posterior root ganglion, anterior root, posterior root and anterior root. And here, this is the relationship. Look at the sympathetic chain, which is just lying on the tip of the transverse processes of the vertebra. And therefore, if you see someone who has got the transverse process of the thoracic and lumbar spine fracture, you have to think whether they have damaged their sympathetic chain, because it is not far, it is just there, because these transverse processes are very deep down in the body. They are covered with multiple layers of the muscles of the body, and if they are damaged, that energy is pretty high, and if the energy is high enough to fracture this transverse process, they can also damage the sympathetic chain. So now, this is a little bit mix-up diagram. It is so the spinal nerve, that's what showing from this diagram as well. So I want you to sit down and think, let's start with the easy bit, which is the number 2, somatic afferent. So this is the touch, temperature, pressure, sensation coming from the receptors from the periphery, coming into the spinal cord. So before it goes into the spinal cord, it has got dorsal root ganglion. There will be synapse, and then another nerve come into the spinal cord from the posterior root. Right. So if you just give yourself time, just try to have a look. It is a little bit awkward. Yes, we have talked about this. The sympathetic or parasympathetic, in other words, autonomic nervous system motor neurons are situated in the anterior and lateral horn of the gray matter of the spinal cord. What do we have here? We have the somatic motor. We have the somatic motor here, and on the slightly lateral and anterior, we have the visceral motor here. So this motor neuron originating from the anterolateral region of the gray matter of the spinal cord. This must be the visceral motor neuron. So, and leaving the visceral motor neuron, it came out from the anterior root and come into the, join with the posterior root to form the spinal nerve, and then they will go into the sympathetic change via the white ramus, and there will be relay here. Look at that, there is a relay, and there will be a synapse, and this is what we call the preganglionic neuron, before the neuron before the ganglia, preganglionic neuron, and there will be synapse here. The information will be transferred to the post-ganglionic neuron, which is here and which is running through the gray ramus. So gray ramus is an exit, white ramus is an entry into this sympathetic chain, sympathetic ganglia, and second, post-ganglionic neuron will leave from the gray ramus and leaving along here. So this is the post-ganglionic neuron, and therefore post-ganglionic neuron is long and pre-ganglionic neuron is pretty short comparing to the post-ganglionic neuron. Okay, so that is one way to do the transfer. Another way is, you know that they go one level up or one level down, and then they will leave along the gray ramus. Or number three, they will not even relay at all in the sympathetic chain, and they will go to the pre-vertebral. So it is in front, look at that, it is in front of the vertebral column, in front of the spinal cord. There will be a collateral ganglia. This ganglia is called collateral ganglia, and then they will leave, and then they will go to the target organs. So roughly, how many prevertebral collateral ganglia do we have? We have like about three main, like around the celiac trunk, the artery from the aorta, celiac, only one and single branch, which is celiac, superior mesenteric, and inferior mesenteric. So around these arteries, there will be sympathetic collateral ganglia, which are also called prevertebral ganglia. So there will be celiac collateral ganglia. There will be superior mesenteric prevertebral or collateral ganglia, and inferior mesenteric collateral ganglia, and then they go to here. So sympathetic has got three ways. Two ways, one coming into the right sympathetic chain or left sympathetic chain, or another way is to come directly to the prevertebral sympathetic ganglia and then go to the target organ. So now we are looking at the same diagram from different angle. Look at the relationship. Look at the relationship. These are the vertebral bodies, and these are the blue color is intervertebral disc, and this is spinal cord inside the spinal canal. You can this is the sympathetic, therefore it is the thoracolumbar. Therefore we see the ribs coming out from the vertebral bodies. Look at that. This is the intercostal muscle, which is colored with red, intercostal muscle, and you can see the nerve fibers along the coming here. You can see the white color, white rami communicandi coming into the sympathetic chain and leaving as gray rami communicandi and leaving the sympathetic chain, and we proceed. Or some of the fibers will not bother at all. We go to the prevertebral sympathetic plexuses, nerve plexuses, which are called prevertebral plexuses, or which are also called collateral vertebral plexuses. The names are celiac, superior mesenteric, and inferior mesenteric. So these prevertebral plexuses are only present in the abdomen, in the abdominal cavity, and they follow the arteries of the single abdominal, a single artery arising from the abdominal aorta, which are celiac artery, superior mesenteric artery, and inferior mesenteric artery. So these sympathetic prevertebral collateral plexuses are located around the celiac artery, superior mesenteric artery, and inferior mesenteric arteries. And the parasympathetic chains are located on the either side of the vertebra. Look at that. So this is the right sympathetic chain, this is the left sympathetic chain, and this will be the plexus for prevertebral nerve plexuses, especially around the celiac, superior mesenteric, and inferior mesenteric artery. Look at that. This is the same diagram, which is the vertebra body, intervertebral discs, ribs coming out. This is the pedicle of the vertebra. This is the lamina of the vertebra. This is the transverse process of the here pedicle and lamina. And this is the spinous process. This is the transverse process. And inside the spinal canal, pedicle and lamina, we create a spinal canal. Inside the spinal canal, we have the spinal cord here, and leaving, and on either side of the vertebral body here, we have the sympathetic chain. This is the right sympathetic chain, and this is the left sympathetic chain. Right, and that is the simple drawing of this lovely diagram here. So now it is like nearly 11 o'clock, 10 past 2 minutes to 11. So I will give you a little break before we start the second part of this lecture. And if you look at that as before you leave, and this is the diagram you have seen, which is on the right side, we are showing the sympathetic, and on the left side, we are showing the parasympathetic. Of course, both sympathetic and parasympathetic will be present on right and left side. And parasympathetic is craniosacral, cranial nerves 3, 7, 9, 10, and sacral S1, 2, S2, 3, 4. And sympathetic is thoracolumbar, starting from the thoracic 1 to ending at the thoracic 2 or might be thoracic 3 level. And parasympathetic preganglionic fibers are long, close to the ganglion, and postganglionic fibers are short. In the sympathetic, preganglionic nerve fibers are short, go to the ganglia, and postganglionic fibers are long. Postganglionic fibers are long, and they go, especially in the abdomen, look at that, they go into the celiac, superior mesenteric, and inferior mesenteric ganglia. They go to the one and single branch of the aorta, which is celiac artery, superior mesenteric artery, and inferior mesenteric artery. So these nerve plexuses follow the celiac ganglion, superior mesenteric ganglion, and inferior mesenteric ganglion. And after that, they go to the target organs. So preganglionic, postganglionic. And on the sympathetic, we have two ways to go to the ganglia. They will go into the sympathetic chain, or they will go to the prevertebra, these big sympathetic, celiac, superior mesenteric, and inferior mesenteric ganglions. Okay, so now let's go for a break. It is 11 o'clock. We will meet 11:15. Go away, have a glass of water, have coffee, have a fresh air, but please do come back. Please do come back. And we might be able to finish this autonomic nervous system today. That will be cool. Then we can go to the special senses on Friday. Yeah. All right, guys. See you in 15 minutes, 11:15.
Professor?
Yep.
I have a question. I didn't see in my email the slides for today's lecture.
Oh, okay.
Could you send those for me, please?
Yeah, I will send it now.
Okay, thank you.
Yeah. Oh. So as you saw in our previous diagrams, we have the paravertebrae on either side, on right and left side of the vertebra. We have the sympathetic chain, or we can also call sympathetic ganglia. Chain means is all along, and ganglia are the beads, little beads of the connection of the neural synapse. And we have the prevertebral ganglia, or sympathetic collateral or prevertebral ganglia, which we saw like around the celiac, superior mesenteric and inferior mesenteric arteries. So the paravertebrae are paired and prevertebrae are unpaired. So it is only one and single. It is just like very similar to the arrangement of the arteries, arteries around the abdominal aorta, like pair arteries, like renal arteries, testicular arteries, gonadal arteries, and unpaired arteries are celiac, superior mesenteric and inferior mesenteric. The same thing like paravertebral chain and paravertebral ganglia are on either side of the vertebral column, and unpaired are prevertebral, celiac, superior mesenteric and inferior mesenteric. So the sympathetic chain and sympathetic ganglia change, and ganglia change mean all along, running from thoracic 1 to lumbar 2, lumbar 3 region, and there will be little beads. These are called the ganglia. So there are a few need to know ganglia, which are cervical ganglia. Where are they? Cervical ganglia are anterior to the transverse process of the cervical vertebrae. Where are the thoracic ganglia? Thoracic ganglia are on the heads of the ribs. Lumbar ganglia are on the anterolateral side of the vertebral body, and sacral medial to the sacral foramina, and coccyx anterior to the coccyx. What am I talking about? What am I talking about? So let's say I'm going to show you the same diagram again. So these are the ganglia. So we have at the level, although the cervical does not directly contribute, lower cervical, we come and join the thoracic 1 ganglia. So these ganglia, they are here. So if this is the thoracic ganglia, which is at the head of the ribs, that's what they are talking about. Yeah, that's what they are talking about. So the thoracic ganglia are on the head of the ribs, cervical ganglia at the tip of the transverse process of the cervical vertebra, lumbar on either side, anterolateral side of the vertebral body, and sacral medial to the sacral foramina. So sympathetic collateral or prevertebral ganglia, they are not paired. We know that they are not segmentally arranged. They are located anterior to the vertebral bodies and only in the abdomen and pelvis. What are they? They are celiac, superior mesenteric, inferior mesenteric. And here they said inferior hypogastric ganglia as well. Hypogastrium, inferior hypogastric ganglia. Look at that, look at that. This is the abdominal aorta, which is color with red, and abdominal aorta is divided into right common iliac and left common iliac, and you can see the paired artery, which is the renal artery, right renal artery, left renal artery. We cannot see right gonadal and left gonadal artery, and there are unpaired arteries arising from the abdominal aorta, which are celiac trunk, celiac artery, superior mesenteric artery, and inferior mesenteric arteries. And the sympathetic change, look at that. On one side, we have sympathetic change and its ganglia. And on the left side, we have sympathetic chain and its ganglia. Look at that. Hey, look at that. That's what we are talking about. You know, in the sacral region, like all this right and left here as a inferior hypogastric plexus, and in the coccyx is only one and single. That's what it was talking about. So some of the fibers, they do not synapse in the sympathetic chain ganglia, and they will come to the region of the celiac trunk to form the celiac ganglia. They will come to the superior mesenteric to form the superior mesenteric ganglia. They will go to the inferior mesenteric, they will go to the inferior mesenteric ganglia. And there will be superior hypogastric and inferior hypogastric. And in the coccyx, there is only one and only ganglion impar. Look at that. That's the arrangement here. That's the sympathetic chain, which is paired, right sympathetic chain, left sympathetic chain. Along the chain, we have the ganglia, and impaired, one and single, prevertebral, here celiac, superior mesenteric and inferior mesenteric, and hypogastric. Of course, hypogastric has superior hypogastric and inferior hypogastric. Right sympathetic chain, left sympathetic chain come and join here as in the coccyx as a ganglia impar. Ganglia impar. Look at that. That is the beauty. Very lovely diagram here. Synapse. So what is a synapse? Synapse is the junction between the two neurons. So we saw that. We saw in the sympathetic chain, there is synapse between the preganglionic neuron and postganglionic neuron. What is a ganglia? Ganglia is the collection of neural cell bodies. Okay, so we saw that there is a preganglionic neuron and beginning of the postganglionic neuron. So these neuron cell bodies combination is called ganglion. So preganglionic neuron, postganglionic neuron, and they will be starting in the ganglia. Yes, sympathetic ganglia along the sympathetic chain. Synapse is a junction between the two neurons. So now we come back here and see this diagram again. So this diagram seems a little bit easier, but I'm going to repeat that again. It is the sympathetic and parasympathetic. Sympathetic is for fight and flight, or the adrenaline process for sympathetic. Parasympathetic is rest and digest. You are taking easy. So fibers for the sympathetic come from thoracic and lumbar region. Fibers for the parasympathetic come from cranial and sacral region, craniosacral outflow. So now we know that which organ is going to get supply from the sympathetic and parasympathetic. The way we try to remember is all the visceral organs are supplied by both sympathetic and parasympathetic. So every organ which is more visceral are supplied by the sympathetic and parasympathetic. They need to be balanced. There are only a few exceptions like liver, kidneys, blood vessels. The liver, kidney, blood vessels, you know, these organs, they are only supplied by the sympathetic. Adipose tissue, cell metabolism. So these organs are only supplied by the sympathetic. There is no parasympathetic. But the way we try to remember, just generalize. Every organ supplied by sympathetic and parasympathetic, except liver, kidney, adipose tissue, cell metabolism, that sort of stuff. Okay, let's move on. So now this is a diagram from our textbook. If you see that coming from the brainstem and the sacrum, you know that this is the parasympathetic. Yeah, you know that this is parasympathetic because there is nothing contribution from the thoracic and lumbar region. So this is the parasympathetic nervous system. Of course, we have on the left, these fibers will come out from the left, and there will be right. For the clarity of the diagram, we remove the right side. So let's look at carefully. And for the cranial nerve 3, third cranial nerve, which is also called oculomotor nerve. Oculomotor, as we know, oculomotor, movement of the eye and levator palpebrae superioris. So these oculomotor nerve is here. The nerve fibers come out, they go to the ganglia here, which is called ciliary ganglia, and that will go to the eye here. And the postganglionic fiber will go to the eye. Look at the 7th cranial nerve. We go to the pterygopalatine ganglia, go to the maxilla and lacrimal gland here. Look at that. And they will go to the, again from the 7th cranial nerve, they will go to the submandibular ganglia. We go to the submandibular and sublingual gland for salivary glands here. So salivation is from the 7th cranial nerve. If you see something and if you want to eat something and you got saliva in your mouth, that is the 7th cranial nerve, which is the coming from the submandibular ganglia. Okay, what about the 9th cranial nerve? Hey, look at that. It goes to the otic ganglion and it will go to the parotid gland. What is the parotid gland? Parotid gland is the another salivary gland. So 7 and 9 is making you produce saliva. Yeah, that's easy. And look at that 10th cranial nerve, vagus nerve. Vagus is what we call vagus wandering around. Look at that vagus coming from the brain. Look at that, it's just go everywhere. You know, go to the heart, go to the lungs, go to the liver and gallbladder here, and go to the celiac plexus, and then go to the stomach here as well. So the cranial nerves are going everywhere, you know, but except the exception we talk about. So now look at the sacral outflow. Sacral outflow coming out from the S2, 3, 4, go into the combination of this is called the pelvic splenic nerves. So these nerves are called pelvic splenic nerves, and then they go to the inferior hypogastric plexus. You saw that inferior hypogastric plexus, and then they will lead to the rectum, urinary bladder, uterus, and the external genitalia, penis, clitoris, and vagina. Look at that. They are all widespread around. Yeah, that's the parasympathetic. Yeah, you can see the long preganglionic neurons and short postganglionic neuron here. Sure, they just go close to the organ they are going to target, and then they change into the, they change another neuron start, and then they go to the organ. So postganglionic neurons or postsynaptic neurons in parasympathetic are short. Presynaptic neurons are long in the parasympathetic nervous system. Now we are seeing the paired structure. Look at that, you know, on either side of the vertebral column. So there will be one on the left, there will be one on the right, and they are like a beads, which are called ganglions. This change has got beads. That's why this must be the sympathetic change or sympathetic trunk. Look at that, it is all along the thoracic 1, go into the lumbar 2, 3. Look at that. And as we know, there is no direct cervical spine contribution, and we create it as the superior cervical ganglion, coming from the cervical region. Middle cervical ganglia here, they are all like, you know, they are not coming directly from they just all combine to form the superior. All the cervical ones, they come out to do this, to form the superior cervical ganglion, middle cervical ganglion, and inferior cervical ganglion, which is called the stellate ganglions. Look at the stellate ganglion. Stellate ganglion is the combination of lower cervical, especially cervical 7 or 8, and epithoracic, thoracic 1. Thoracic 1 ganglion is also called stellate ganglion, which takes contribution from the cervical 7 might be, or cervical 8. And this is the ganglion we were talking about, which gives the problem. If there is any damage to the stellate ganglion, we got the Horner syndrome. But look at that in general, on either side of the spinal, we got the right and left sympathetic change, and some fibers we meet in the center here, and some fibers we follow the bronchi, and look at that. And in the abdomen, look at that right and left sympathetic change together with the ganglia. They will continue long, although they do not take contribution into the pelvis, and they form the superior and inferior hypogastric plexus. Of course, superior and inferior hypogastric plexus, the parasympathetic will join as well. And finally, pelvic sympathetic trunk. Look at that, pelvic sympathetic trunk. Of course, they are running, but they are not contributed from this sacrum. They are only contributed from the thoracic and lumbar. So now, one thing to remember, as we say, like from the anterolateral horn region, the visceral motor neuron originate, come out from the ventral root, and some of the fibers will go along the white rami. Some of the fiber will synapse and continue as postsynaptic. Some will go 1 or 2 level up or 1 or 2 level down, and some they do not synapse in the sympathetic change, and they will go to the prevertebral plexus, or some they will go to the adrenal gland. Look at that. This sort of sympathetic change for adrenal gland is coming directly into the adrenal medulla and give directly to the adrenal medulla. And therefore, people say, adrenal gland, especially adrenal medulla, is also another type of ganglia, because the presynaptic neurons come directly into the adrenal medulla, and therefore they are also called as ganglia, because the preganglionic neuron directly come into the adrenal medulla region. And they, of course, adrenal medulla will secrete epinephrine and norepinephrine. So visceral sensory neuron, when we talk about the autonomic nervous system is mainly for motor, and we divide into sympathetic and parasympathetic. Now I'm going to just a little bit repeat about the visceral sensory. So this page is not related to the autonomic nervous system, but because there are a few little things which are connected, therefore I have to bring this sensory system here. And as we all know, autonomic nervous system is motor system for the visceral organ, so it is not for sensory. So this visceral sensory neuron is not related to the autonomic nervous system, because we have been giving motor supply to all the organs. So what's happened if these organs have any problem? Let's say if there is any increased acid in our stomach, which we present as hangry. If there are lots of food in our stomach, the way we present is the stomach has been stretched and fullness. The pain is a little bit, not a sharp pain. So if you have stomach ache, the pain is vague in the epigastrium. If you have belly ache, you don't really pinpoint easily the region. And nausea is also you just want to feel sick and want to vomit. You don't really, there is no specific site you can identify. So all these presentation are detected by the stretch receptors, temperature receptors, chemical changes receptor, irritant receptor, and then they will all go along the visceral sensory neuron. And they have very poor precision. So at the very beginning of the belly ache, like appendicitis, you don't really feel like, oh, right lower quadrant or right hypogastric pain, right inguinal region pain. You don't really feel it. The appendicitis pain just start with vague belly pain, isn't it? So you might feel a little bit nausea. You don't really know. Belly is a little bit achy, especially around the umbilical region. And only after that we localize to the right inguinal region or right iliac region. So when we have right iliac fossa pain, the appendicitis has gone on for a few hours already. So because at the beginning, the appendicitis present with just a belly ache, belly discomfort around the umbilical region. So this is very poor precision. And visceral sensory fibers will follow the parasympathetic nerve fibers or sympathetic nerve fibers. Because these sympathetic and parasympathetics are motor and sensory, we follow these fibers. So that's what I want to show you. And what is this? This is the dermatome. Yeah, you remember that dermatome like shoulder tip, cervical 5, C5. Thumb dermatome is C6. Middle finger dermatome is C7. Little finger dermatome is C8. Medial aspect of the forearm is thoracic 1. Medial aspect of the arm is thoracic 2. Nipple line, thoracic 4. Xiphisternum, thoracic 8. Umbilicus, thoracic 12. Suprapubic, just above the pubic symphysis, is thoracic 12. And groin, our groin is number 1. Medial aspect of the knee is number 3. Medial malleolus is number 4. And the dorsolateral aspect of the foot is sacral 1. And around the perianal region is S2, 3, 4, 5. So that's the way we have to remember the dermatomes. So these dermatomes, we come and join the vague visceral sensory system. So now we have a map of refer pain. So look at that, the gallbladder. Where do we have gallbladder pain? Might be right hypochondrium or might be epigastric pain. So especially ladies in their 45, 50 who is a bit obese, they have a few children, a few kids. So the way we try to remember is fat, female, fertile, 40, 50s. So 5F. And these are more prone to gallbladder stone, and they tend to get pain, discomfort around the just below the hypochondrial region or umbilical region. And liver pain can go to the shoulder region. Why is that? You look at that. Gallbladder pain is shoulder. Liver pain around the shoulder. Why is that? Because they are close to the diaphragm. Diaphragm is supplied by the phrenic nerve, which is the cervical 3, 4, 5, and the shoulder tip is the dermatomal region is cervical 5. So they are all connected, and therefore the gallbladder pain we present here as well as the shoulder region. And the same thing, like if someone has got free flowing blood in the abdominal cavity, and this blood will go and irritate the diaphragm. And therefore, if the diaphragm get irritated, cervical 3, 4, 5, 5 is irritated, and the 5 distribution sensation is here. So shoulder tip pain as well. Because it's a refer pain. The shoulder tip pain is coming from the diaphragm. It is not related to the shoulder. So always have an open mind when you see a patient with the pain. So pain pain, it could be just local pain or might be referred from another region. And look at that, the ureters, look at the ureters. Ureters are here. But actually, ureters are along here from the kidney down to the bladder, isn't it? But the pain is here. Why is that? The lumbar one. So the groin is supplied by the lumbar one dermatome, and therefore, and kidneys are in the lumbar 1, 2, 3, might be thoracic 12 to lumbar 2 region, and therefore the renal colic give pain in the groin. It is just like, refer pain as well. Look at the appendix pain, yellow color here. It is usually start with the paraumbilical pain and finally localized to the appendix, which is somewhere around here. And chest pain, look at the heart. Heart is here. Heart is, all the visceral pain here. Look at the chest pain. Hey, left chest wall pain. Look at the left pain in the medial aspect and of the arm and medial aspect of the forearm. Why is that here? Even the little finger is supplied by cervical 8 dermatome. Medial aspect of the forearm is supplied by thoracic 1 dermatome. Medial aspect of the forearm, thoracic 2 dermatome. Chest wall is here supplied by thoracic 2, 3, 4. And therefore, nipple is thoracic 4. And therefore, the cardiac plexus is originating from there. And therefore, we got this pain here. And at the same time, we have the neck pain as well from the heart. Look at that. That is the distribution. That is what we call referred pain. Now we got to the little bit easier portion of the autonomic nervous system. So I will just vaguely go here, and we will just go into a little bit more repetition on Friday. Yeah, so the baroreceptor reflex. So here, where do we have baroreceptors? In the carotid sinus here. So the blood volume goes down, blood pressure, and this baroreceptor detect, and they go to the cardiac center in the brainstem, midbrain, pons, and medulla oblongata. Sensory impulses are carried on visceral sensory fibers in the glossopharyngeal nerve, cranial nerve 9. Look at that, cranial nerve 9 will carry the information from the baroreceptor. Increase in blood pressure, then baroreceptors will be stimulated. The 9th cranial nerve will carry the increased blood pressure sensation and go to the cardiac center, and then integration occur in the cardiac center in the medulla oblongata, and efferent pathway via the cranial nerve 10. Look at that, cranial nerve 10. Vagus nerve come back here. Parasympathetic stimulation for the heart, decrease the heart rate, and blood pressure goes down. So this is the reflex. That is what we call baroreceptor reflex. Why am I showing that? Because that is the sensory and motor combination, which is the visceral sensory and visceral motor. Visceral sensory is the baroreceptor, which detect the blood pressure changes. In other words, like increase or decrease the blood pressure changes. Baroreceptor will detect. That information will be by the 9th cranial nerve to the brainstem and go to the cardiac center in the brainstem and come back out via the 10th cranial nerve, and we go and act on the heart. So if the blood pressure is up, the 9th cranial nerve will go up, 10th cranial nerve will come down, and more vagus stimulation, the heart rate will go down. Parasympathetic decrease the heart rate will go down. Let's say if our blood pressure is low, baroreceptor will stimulate, and the nerve along the ninth cranial nerve will go to the cardiac center, and there will be inhibition of the vagus nerve. And because less influence from the vagus, the heart rate will go up and blood pressure increase. This is what we call the baroreceptor reflex, which is the combination of visceral sensory and visceral motor. So what about the defecation reflex? Defecation reflex as well, if you look at that, external anus sphincters, which is the skeletal muscle here, that is the voluntary skeletal muscle. So that is our voluntary control. If the situation is not appropriate, we can squeeze and make the external anus sphincter to work hard. But that is from the cerebral cortex. Yeah, inappropriate. Hey, impulse from the cerebral cortex come down along here, voluntary motor along the somatic motor. Yeah, this is somatic motor and going to stimulate the external anus sphincter. But what is happening inside? What is happening with the autonomic? So feces move into the distended rectum. So rectum has been filled with lots of feces already. The rectum is being stretched already. All these stretch receptors, look at that, stretch receptors here, stretch receptor in the wall, they will go to the spinal cord, and the spinal reflex is here. Just come back and let this, what do you call that, the internal anus sphincter to relax. That is the reflex. Therefore, if we have if we have lost our cerebral control, like for example, spinal cord injury patients, they still have local spinal, let's say, thoracic spinal cord injury. So they have lower spinal cord is intact, and therefore they will still have this reflex. So therefore, this spinal cord injury patient, when their rectum is filled with feces, they just pass. They become incontinent because their upper cerebral cortex control is lost. They still have the local spinal reflex, and therefore they will, just like they will pass. They don't know. And this is a micturition reflex. That's the same like the what you call the defecation reflex, and visceral reflex, defecation reflex, micturition reflex, and baroreceptor reflex. That's what we talk about. So finally, the levels of the autonomic nervous system control. So as we know, autonomic nervous system is, it is driving on its own. Yeah, we don't really need to get involved, but we tend to get involved to the autonomic nervous system from the higher center. From the cerebral cortex, frontal lobe, from the limbic system. Limbic system is related to the emotion. So if you see something emotional, and if you are thinking something emotional, they are coming into subconscious level, and that way influence our autonomic nervous system. Of course, we are fine if we are not thinking anything, and our heart rate is about 70, 80. Our respiration is about normal, 12 to 16, and we are fine. And once we start thinking something which influence our mind, and from the frontal cortex and limbic system, like emotionally, something coming in our mind, and our heart rate will go up. So that is the relationship between the higher center, frontal lobe, limbic system, and the autonomic nervous system. The same thing, like, hypothalamus, all the sensory, as we say, all the sensory, visceral sensory, we have to go through the hypothalamus. So like if we touch something and if it is hot, this is very disturbing. My fingertip is hot. And then we go to the hypothalamus and it stimulates the sympathetic and my heart rate will go up because all the sensation come into the autonomic. The brainstem reticular formation to regulate the pupil size, heart rate, blood pressure, the breathing, salivation, and spinal cord will influence the urination, defecation, erection, and ejaculation, all the reflexes here. So that is the relationship between the higher center thinking and the autonomic nervous system. And to make it short, autonomic nervous system is competent on its own, but we do influence from the higher center. So not consider central control of the autonomic nervous system. It's not considered to be under voluntary control. Yes, we know that. We think something exciting and our heart rate will go up, increase sympathetic. We are not influencing how fast our heart is going to be beat, but it is just like, we just kick in. But it is not our voluntary control, We are getting excited and we try to control our heart rate. We cannot do that. It's just start in our frontal lobe and limbic system already to stimulate the sympathetic autonomic nervous system. So it's CNS will regulate, but it is not under control. And cerebral cortex, hypothalamus, amygdala body, brainstem, spinal cord, they will all influence on the autonomic nervous system, although autonomic nervous system is competent on its own, working on its own, without brain, cerebral cortex, without hypothalamus, without amygdala, without brainstem and spinal cord. So a few more diagrams to show, guys. What is this? This is a condition called Raynaud's. The phenomenon, Raynaud's phenomenon is called white, blue, red, and pale. White, blue, red, and pale. That is the condition called Raynaud's phenomenon, especially extremities like our fingers, our hands, or our toes, or our feet. So what's happened is this patient just go and expose his hands or her hands in the cold, like go and grab the snow. And what happened is the hands and fingers will go white. Why do they go white? Because of the vasospasm, the spasm of the blood vessel, sympathetic, blood vessel become narrowed, squeezed, and no more blood flow to the fingers and digits. That is why these patients will start with the white. And because there is no blood flow because of the vasospasm, then the cells in the fingers, hands, they become cyanotic. They go into because of lack of oxygen. Therefore, the color will change from white to blue. And finally, if they remove it, and then make it warm, make the finger warm, and then there will be another blood flow. The vasospasm relax, and more blood flow back to these digits. And therefore, extreme rush of blood to these digits, causing the high blood flow, causing the red color. And finally, of course, the cells, at least for some time, they lack oxygen, and therefore they present as cellular hypoxia and pain. So that is what we call white, blue, red, and pale. This sequence is called Raynaud's phenomenon. And Raynaud's phenomenon can be seen in Raynaud's disease. So this is the excessive response, sympathetic response of the blood vessel, sympathetic system response, and this present as this Raynaud's phenomenon. And as we see, like, the Horner syndrome is thoracic 1 ganglion, stellate ganglion injury will present with the ptosis, meiosis, and hydrosis. That is the thoracic 1 sympathetic chain, sympathetic ganglion presentation. And this is another Raynaud's syndrome. And if we see that, we have to make sure the patient does not have the apical lung tumor. So apex of the lung here, we can see the radio-opaque shadow. What is that? We need to investigate, because the patient is coming, and one of the causes of the Horner syndrome is that Pancoast tumor, which is the apical lung tumor. Yes, there are a few other causes like syringomyelia, trauma to the thoracic 1 ganglion, carotid endarterectomy. So now it comes to the end of the lecture, guys. So that is the autonomic nervous system, which is the motor system for the viscera. Autonomic nervous system is for the motor for the viscera, and motor for the somatic voluntary muscle is called somatic nervous system. Motor for the viscera is called autonomic nervous system, which includes sympathetic and parasympathetic. And I like this diagram: sympathetic and parasympathetic, craniosacral outflow, and thoracolumbar outflow. And if you look at that, although it ends in the thoracic 2 or thoracic 3 region, this sympathetic change go into the sacrum and pelvis region. You can see that, and they will connect in front of the coccyx as a ganglia impar. So look at that. Although the sympathetic is formed from the thoracic and lumbar, it goes into the sacrum and pelvis region. So, and parasympathetic, they are from the cranial nerves or they are from the sacral nerve. All right. Has anyone got any question, or was it too much?